Hi, Dr. Stein, Dr. Elisa, and dear colleagues. Today, I'm going to present cervical artery dissections and its relationship with migraine and how do cervical artery dissections affect migraine patients and in chronic migraine patients and in other primary headache patients. Let me first start with the description of the migraine. Today, I will talk about cervical artery dissections, but to give you a better understanding, I will share the migraine descriptions of International Classification of Headache Disorders. It's the latest classification, and I took it from the website of International Classification of Headache Disorders. The description of the migraine is like recurrent headache disorder, manifesting in attacks lasting 4 to 2 hours, and its characteristics are the unilateral location in one side, pulsating or throbbing quality, moderate or severe intensity, aggravation by physical activity, and association with either nausea and or phonophobia, and sometimes we see in the clinic osmophobia. And the diagnostic criteria are I think most important for migraine to diagnose it. And the criteria A is at least 5 attacks fulfilling criteria B and D. And what are B and D? B to D. It is B, headache attacks lasting 4 to 72 hours, and they are either untreated or unsuccessful treated. And headache has at least 2 of the following 4 characteristics. What are those? That I mentioned before: pulsating quality, unilateral location, moderate or severe pain intensity, and aggravation or causing avoidance of routine physical activity. And the criteria D is during headache, at least one of the following should present: either nausea and or vomiting, or either phonophobia or phonophobia. I think it's not N. And it won't be better accounted for by another ICHD3 diagnosis, because there are many primary headaches and many diagnostic criteria. There are diagnostic criteria for each of them, and it won't be better accounted for by another ICHD3 diagnosis to diagnose a patient migraine without aura. And what are differences of migraine with aura? It's the same recurrent attacks lasting minutes this time, of unilateral, fully reversible visual, sensory, or other central nervous system symptoms that usually develop gradually and are usually followed by headache and associated migraine symptoms. And it can be anything, like they can see colors sometimes. It can even be a darkening in the vision. It can be a sensation, like a touching sensation, like hearing. It can be even smell. But the most important, it precedes the headache and it's followed by headache. And the diagnostic criteria are this time at least 2 attacks fulfilling criteria B and C. What are those? 1 or more of the following fully reversible aura symptoms, either visual, sensory, speech and or language, motor, brainstem, retinal, as I thought, can be like many things. And at least 3 of the following 6 characteristics: at least 1 aura symptom spreads gradually over more than at least 5 minutes. 2 or more aura symptoms occur in succession, and each individual aura symptom lasts 5 to 60 minutes. At least 1 aura symptom is unilateral. At least 1 aura symptom is positive, and the aura is accompanied or followed within 60 minutes by headache. You can see all of them at the same time cannot happen, but the 3 of them will be enough. And again, not better accounted by another ICHD3 diagnosis. And the last, chronic migraine. And the chronic migraine is headache occurring on 15 or more days per month for more than 3 months, which on at least 8 days months has the features of migraine headache. So it will be like present more than half of the months, as you see, and like at least in the quarter of the month, it should present the features of migraine headache. and it will be enough. And in the other half, maybe it can present like tension headache, but even then we can diagnose like chronic migraine. And here are the diagnostic criteria. As I said, headaches on, or I said that, and fulfilling criteria B and C. Criteria B is occurring in a patient who has had at least 5 attacks. Fulfilling criteria B to D for migraine without aura, and migraine with aura, criteria B and C. And on at least 8 days per month for more than 3 months, fulfilling the criteria of migraine without aura and migraine with aura, and believed by the patient to be migraine at onset and relieved by a triptan or ergot derivatives like migraine attack medications. And it's again not better accounted for by another ICHD3 diagnosis. And the red flags for secondary headaches, because you all know there are primary headaches like cluster headache, tension headache, like migraine headache with aura, without aura, migraine status, chronic. But there are also secondary headaches that are caused by another like primary disorder, and it can like there are more secondary headaches than primary headaches, as you can guess. And this is the mnemonic for secondary headaches. What can cause secondary headaches? S for like Snoop 10, S for systemic symptoms such as fever, and for neoplasm in history, like you can think vestibular schwannoma or cerebellopontine angle tumor, like for example. And neurologic deficits or dysfunction, like you can suspect from secondary headaches, because if patient presents with headache and it has neurologic deficit or dysfunction, maybe it can be a stroke or any neurologic diseases. And if the onset of headache is sudden or abrupt, also this is not typical for primary headaches, we should suspect secondary headaches. And older age, like typically greater than 50, we don't expect patients older than 50 like present with new onset headache, we should suspect. And the P10, there are pattern change, like a previously migraine patient, the pattern of the headache changed abruptly. We will see on my following slides. It can be cervical artery dissection. And positional headache, like, and I can give an example as like medication overuse headache for this, for positional headache, and precipitated by Valsalva, papilledema, like intracranial pressure increase, pregnancy or puerperium, pain, full eye with autonomic features, post-traumatic onset, pathology of the immune system, medication overuse, or new drug use. And this is the description of cervical carotid vertebral artery dissection, because when I say cervical artery dissection, I mostly talk about carotid and vertebral artery dissections, and they are also, you know, anatomically cervical artery dissection, but carotid and vertebral arteries have also intracranial segments, but now I'm talking about just cervical segments. And there are the most common presentation of these I will talk about later: headache or face or neck pain, mostly neck pain or headache. And there's also a classification in ICHD3 headache disorders classification. And let me read the classification. It says like headache and or pain in the face and or neck caused by dissection of a cervical, carotid or vertebral artery. The pain is usually ipsilateral to the dissected vessel and generally has a sudden onset, like thunderclap, as I mentioned before in the previous slide, and it can remain isolated or be a warning symptom preceding ischemic stroke. And it's not always presenting with ischemic stroke. It can just present with headache, and I will talk about later. And the diagnostic criteria are any new headache and or facial or neck pain, fulfilling criteria C and D, and cervical, carotid or vertebral dissection has been diagnosed. And the C and D are C, evidence of causation demonstrated by at least 2 of the following. Pain has developed in close temporal relation to other local signs of the cervical artery dissection, or has led to its diagnosis, or either of both of the following is the 2. Second, pain has significantly worsened in parallel with other signs of the cervical artery dissection, or pain has significantly improved or resolved within 1 month of its onset. It's like vice versa, because it's not fully understood yet, but it can cause change, as you see. And the third of the C criteria, C, is pain is severe and continues for days or longer. And we also see like painkiller resistance, and some patients like alerts if their headache doesn't respond to painkillers, and pain precedes signs of acute retinal and or cerebral ischemia. And fourth is pain is unilateral and ipsilateral to the affected cervical artery. And criteria D is either of the following: headache has resolved within 3 months, and headache has not yet resolved, but 3 months have not yet passed. Like it's like an exclusion criteria, as you see. And again, as always, not better accounted for by another ICHD3 diagnosis. And I want to talk about the etiology of cervical artery dissections, what can cause, and also I'm working on an ongoing research about cervical artery dissections and headache. The etiology of cervical artery dissections is more than 50% of cases are spontaneous, and 40% of the cases are trauma. So like more than 50%, like more than half of them are spontaneous, but sometimes patients can't remember the event, because if it is a minor trauma, because the 90% of traumas are either mild or moderate, and people don't pay attention to minor trauma, and they don't mention the trauma, so we cannot like spontaneous, it can happen. And the most common causes are, this is interesting, it is the most common cause in USA. This is a research in USA. I put the like source, and the most common cause in USA is cervical chiropractic manipulation, and the others are heavy lifting, sports injuries, and whiplash injuries. Also, and other causes are giving birth, cough, sneezing, vomiting, yoga, vigorous exercise, and I even had like some patients go to the coiffeur and they extend their neck during haircuts, and we also see patients like this, like minor trauma. And the major trauma causing cervical artery dissection are 50% motor vehicle accidents, and others are assault, fall, and hanging. And you know, there's also predilection to cervical artery dissections. And what can cause predilection? Marfan syndrome, fibromuscular dysplasia, like connective tissue disorders, like cystic medial necrosis and autosomal dominant polycystic kidney disease, alpha-1 antitrypsin deficiency, and environmental triggers like our minor neck trauma or manipulation, or infections, neck infections. And risk factors are migraine, hypertension, low level of cholesterol, low body mass index. So we can see in anorexic patients, and like the fat pads in the neck can be protective for cervical artery dissections, and around the vessels, you know, the fat layer can be protective. Also, as I mentioned, connective tissue diseases, infections, and we can see anatomical variations, elongated styloid process. I put 2 images here for normal styloids and elongated styloids to show you like how can it affect it. As you see, it can impinge the internal carotid artery, and also hypertension, smoking, OCPs, oral contraceptive pills, and pregnancy, and even postpartum period increases the risk. And how it presents clinically, its incidence is 3, like we see 3 cervical artery dissections in 100,000 patients per year. And an important cause of ischemic stroke in young and middle-aged adults is cervical artery dissection, because we don't expect ischemic stroke in like young patients normally, because we see more in older patients. But if it presents in young and middle-aged adults, we can suspect cervical artery dissections. And it is the most common clinical presentation of the cervical artery dissection is headache and or neck pain, and mostly headache. And brain and retinal ischemic findings like follows the headache, and partial Horner syndrome. We can see what is partial Horner syndrome. It is, normal Horner syndrome is meiosis, ptosis, and anhidrosis, and we can see in superior sulcus tumors. But now we don't see anhidrosis, so people can sweat, but we see meiosis and ptosis in cervical artery dissections. We also see tinnitus, cranial nerve palsies, and subarachnoid hemorrhage, like if dissection also includes intracerebral segments, as I mentioned before, intracerebral segments of carotids and vertebral arteries. And this was the article that I took the information before. And it is the newest, most novel article about cervical artery dissections. And the main writer is, my author is Dr. Zafer Keser, MD. And he is in Mayo Clinic, Rochester. And we are doing an ongoing research with him right now in my university in Turkey and in Mayo. And after here, I will be in Mayo, like in next week, I will be in Mayo with him, and I will study on this, on our new research. And cervical artery dissections, most common symptom is headache and neck pain, as I mentioned. And there's this also in a study with 161 patients in this article, 47% of the internal carotid artery dissections and 33% of the vertebral artery dissections, the initial symptom was headache, and solely headache. They just came for headache without any neurologic deficits. And after imaging, they found ischemic stroke in some patients, in some not, but the presenting symptom was headache. And those with internal carotid artery dissection report headaches more frequent at admission, and lower incidence of neck pain and ischemic stroke. And pain in the ipsilateral temporal region of carotid dissection. I put an image here. You can see internal carotid artery affects ipsilateral temporal region. You can see, but it's not always like that. It can be contralateral or it can be bilateral. And vertebral dissections mostly occur at occipital parts. And isolated neck pain tends to be milder than isolated headaches. We see neck pain and people don't alert because of the neck pain usually, and the patient's headache are more severe. And headache in cervical artery dissections. Headache with or without neck pain can be the only manifestation of cervical artery dissection. That's why we need to pay attention if we see a patient like just headache. It can be also a serious thing. It can be a serious complication of cervical artery dissection. It is by far the most frequent symptom, 55 to 100% of cases, and the most frequent inaugural symptom, 33 to 86% of cases of this disorder. And acute headache or facial or neck pain attributed to cervical carotid or vertebral artery dissection, this is the name of the headache type, is usually unilateral, severe, and prolonged for a mean of 4 days. However, it has no constant specific pattern, and it can sometimes be very misleading, mimicking other headaches such as migraine, cluster headache, or primary thunderclap headache. And it's a problem. So because if we diagnose a patient normally with cervical artery dissection as migraine or cluster headache, because it mimics, so it will be a problem in their lives, because their situation is like emergent and needs to like intervention. And associated signs, as I mentioned before, cerebral retinal ischemia, local signs like we can see TIA are common, painful Horner syndrome, painful tinnitus of sudden onset, and painful 12th nerve palsy, and we can see also other cranial nerve palsies are highly suggestive of carotid artery dissections. If they present with headache, you should suspect. Cervical artery dissection may be associated with intracranial artery dissection, which is a potential cause of subarachnoid hemorrhage if the dissection extends to intracranial segments. And headache attributed to intracranial artery dissection, this is also the name in ICHD3 of this headache type, may be present in addition to acute headache or facial or like the headache caused by cervical artery dissection. And acute headache of cervical artery dissection usually precedes the onset of ischemic signs and therefore requires early diagnosis and treatment, as I mentioned before. And there have been no randomized trials of treatment, but there's a consensus in favor of heparin followed by warfarin for 3 to 6 months, according to the quality of the arterial recovery. And that's also an interesting thing. There have been no randomized trials, and it's an open area for research. Also, headache is typically severe, continuous, intense, and throbbing. So that's why it can mimic migraine headache, because it's throbbing. And usually, if patients have previous migraine headache and then they develop cervical artery dissection headache, they can't distinguish it until they don't respond painkiller. Then, oh, my migraine normally responds painkiller, and they can come. Or maybe change in the severity of the headache or change in location, we can see. And rarely it may resemble a cluster headache, but it's really rare. And recent sudden, like thunderclap, persistent severe headache or neck pain, especially when accompanied by other neurological deficits, is deserving our attention. We need to pay attention. Also, I put my sources here. And this is another article, and this is published in Cephalalgia and in International Headache Societies, and the head or neck pain characteristics after spontaneous cervical artery dissection in the acute phase and on a long run. And this is a really helpful article, and it shows how patients with primary headache, how did their primary headaches change, and how did the cervical artery dissection affect their headaches. Sometimes the intensity change, sometimes the character change. Maybe previously it was throbbing and now pulling. And also patients with no previous headache history. What is the character of cervical artery dissection headache? Sometimes pulling, sometimes throbbing. It can change patient to patient, ipsilateral or unilateral, and with percentages, it's very helpful. And I took this image also from this article, and you see here like subarachnoid hemorrhage, cervical artery dissection, and migraine, the locations, gender ratio, and you see migraines more in females, and also cervical artery dissections, but it does not differ that much. Typical age, as you see, like middle-aged adults in cervical artery dissections, and quality, you see migraine throbbing, thunderclap in subarachnoid hemorrhage, and pulling and dull. By the way, it differs from article to article, and in this article, in this research, the patients mostly have pulling type of headache, and in another article it was throbbing, so it changed. It's not always like this. And also accompanying symptoms, you can see cerebral ischemia and cranial nerve affection can accompany the headache, and also in migraine, nausea, photophobia, phonophobia, aura, and subarachnoid hemorrhage, nausea, cerebral ischemia, meningeal irritation, loss of consciousness. It is more serious, you can see. And in this article also they found when the headache is unilateral, always ipsilateral to side of dissection, but it is not like that in other articles. And clinical implications, head and neck pain is the most frequent symptom in cervical artery dissections and can predate cerebral ischemia. Pain characteristically is of sudden onset, pulling nature, continuous in course, and rarely responds to self-administered oral analgesics, as I mentioned before. Pain in cervical artery dissections is characterized as completely novel and can therefore be differentiated from primary headache syndromes in the acute setting. And novel recurring head or neck pain after cervical artery dissection is rare and heterogeneous in quality and intensity. I will quickly talk about pathophysiology. There are layers of the arteries, tunica adventitia, tunica media, tunica intima, and between them external elastic lamina and internal elastic lamina. And it can cause in many ways. It can cause by false lumen, like you can see here, and like it can cause an intramural thrombus, like mural intramural hematoma and complete occlusion. And I will talk about later. It can disrupt the flow and disrupt the blood flow to the brain. And also that's why one of the reasons, if you misdiagnose the patient with migraine, if you give him triptanes, you know what triptanes do? It constricts the vessels, and if it constricts the arteries, and it even decreases the blood flow to the brain more. So it will be a problem. It's an important thing to distinguish. And imaging in cervical artery dissection, as I mentioned before, there are intramural hematoma you see in imaging, double lumen, intimal flap, irregular surface, and pseudoaneurysm. The American Heart Association suggests first step for imaging in cervical artery dissection is CT angiography or fat-suppressed MR angiography. And gold standard for diagnosis, if there's doubt or need for intervention such as standing, is digital subtraction angiography, DSA. And most common findings on imaging: intramural hematoma, flame-shaped tapering of intravessel contrast due to narrowing, and pseudolumen formation you can see here. And I will share another images. Here you can see a bilateral vertebral artery dissections. I don't know if you see my cursor, but you can see here in, I think it's V2 segment, it's bilateral vertebral artery dissections, both-sided. And this was also a patient with migraine, a young girl. And the bilateral vertebral artery dissection happened after heavy lifting, exercising. You can see, like, maybe you can see better in magnified image. And let me talk about the cervical artery dissection and migraine relationship. And there are also other articles. I put my source there here. And 18 to 45-year-old first-time stroke patients, there are 22,485 patients in this category. And all of these, 334 of the patients, like 13.4%, have ischemic stroke due to the cervical artery dissection. And migraines were more common in the cervical artery dissection group compared to those without cervical artery dissection in the other stroke patients. And the rate of migraine without aura was higher. So you see in younger middle-aged patients, 13% of the stroke patients was cervical artery dissection, and migraines were more common. So maybe it can cause a predilation. And the rate of migraine without aura was higher than migraine with aura. The strongest available evidence shows that the risk of cervical artery dissection is doubled in patients with migraine without difference in outcomes between migraineurs and non-migraineurs with cervical artery dissection. And yeah, it's like, I don't know, in this article, they found this, it's doubled in patients with migraine. And yeah, so in some researches, people can show, people found like this result, but another article also, they showed it increases the risk. And a prompt and accurate diagnosis to try to prevent the occurrence of ischemic symptoms is important for migraine secondary to cervical artery dissection. And headache and neck pain are typical clinical features and are often the first symptom of cervical artery dissection. Some case reports and case series have shown that cervical artery dissection can trigger migraine attacks, as I mentioned before, especially with secondary aura. As I told, like, it can change from article to article. And in addition to a few cases of attacks suggestive of migraine without aura, multiple migraine attacks with aura or aura without headache without aura have been described in the acute phase of dissection, both in migraineurs and in individuals without a history of migraine. So we can just see like aura without migraine, and it may suspect us. And the mechanism by which cervical artery dissection triggers, those are hypotheses: asymptomatic aura without or with or without headache. The hypotheses are decreased brain perfusion, which lowers the aura development threshold. Activation of cortical spreading depression by substances released from the damaged vessel. You know, the cortical spreading depression is the supposed cause of migraine. And animal studies have shown that hypoperfusion caused by microembolism can trigger diffuse depression, an intense wave of neuronal and glial depolarization that is considered the electrophysiological substrate of aura. No ischemic lesions were detected in more than half of the animals with disseminated depression. And migraine secondary to cervical artery dissection, if there are unusual aura features, if there's a new onset headache, if there are transient positive or negative focal neurological symptoms or deficits, and if there's a thunderclap headache, if there's a cervical pain, if it lasts more than 72 hours, if it is unexplained, if there are unexplained changes in attack characteristics in migraineurs, and if you see in people who do not have a previous history of migraine, consider cervical artery dissection. And what's the treatment? How do we manage? And 50%, more than 50% of cervical artery dissection has TIA or stroke in this article here. And stroke risk after cervical artery dissection in first 12 months is 2.4%. So it's still high. And there are two components of the treatment. Hyperacute treatment, either thrombolytic or mechanical thrombectomy, and stroke preventive treatment, antithrombotic treatment, and anticoagulants. As I said, there are no such randomized controlled trials, so there is no definite superior treatment, but those are the current treatments. And if there is an intracranial grade artery occlusion, and if the CAD is occlusive, cervical artery dissection is occlusive, stenting is safer. There's another research, 2 multi-center open-labeled international studies investigating the safety and efficacy of anticoagulation and antiplatelet therapies for stroke prevention in cervical artery dissection, the CADIS and TREAT-CAT. I will talk about the studies investigating the safety and efficacy of therapies. And this is the CADIS. There are 118 carotids and 132 vertebral artery dissections. And you can see the antiplatelets and anticoagulants, the site of dissection, and how do they differ. But you can see there are no such big difference between both treatments, and it can change from article to article. And in 126 patients in antithrombotic in CADIS patients, like 55% single antithrombotic and 45% treated with dual antithrombotic. And again, there was no such significant differences with single or dual antithrombotic, and also an anticoagulants. Also in this study, it's near the same. And cervical artery dissection treatment, although not non-inferior to anticoagulants in the treatment of cervical artery dissection, antiplatelet agents are less expensive, require no monitoring, and are easy to use. So there are no big effect differences, but you know, they are less expensive. And acute anticoagulation may be beneficial in patients at high risk of thrombosis, compared to antiplatelet agents like severe stenotic and occlusive dissections, presence of mobile thrombus in the arterial lumen, pseudoaneurysm formation, and positive microembolic signal on transcranial Doppler. And clinical course of migraine after cervical artery dissection. The emergence of cervical artery dissection may also alter the clinical course of migraine, and follow-up studies of patients with cervical artery dissection with ischemic manifestations have highlighted that many migraine patients have shown that migraine attacks improve or even disappear with a frequency of 28 to 92% after the onset of cervical artery dissection. So it can like present as a cure to migraine. It is also interesting, and it's open to research. And the use of aspirin may also play a part, at least partially, in this improvement with its migraine prophylactic effects. And more rarely, de novo migraine may occur after cervical artery dissection. You see, there are two ends of like it can resolve migraine, it can improve migraine, it can cause de novo migraine, and its frequency may reach 15%, although this has not been systematically evaluated in large series yet. You can see it's a new area. We don't see every day like cervical artery dissections, but it is an area open to research and open to enlightenment with further researches. I hope you enjoyed my presentation, and thank you for listening. And I will end this with this caricature cartoon. Thank you.
Okay, wait, still recording? Here we go. Okay. Comments?
It's still recording.
Yes.
Still recording? Stop recording.